everybody. Welcome to Heart Talks with Dr. Gloria. I'm your host, Dr. Gloria Thomas Anderson, and our special guest today on this episode is Dr. Tamara MacGregor. Dr. MacGregor is a Texas-educated physician who grew up in Mineral Wells, Texas. In 1996, she took a job as a hospice medical director and has worked in adult and pediatric hospice for 20 plus years in Dallas. Dr. MacGregor helped start the UT Southwestern Palliative Care program at the University Hospital and Parkland Hospital in 2010. She teaches medical students and residents about family medicine and sees her private patients at the Parkland Family Medicine Clinic. She especially loves teaching students, residents, and fellows about hospice and palliative medicine and is working to integrate hospice and palliative medicine into the UT Southwestern 3-year family medicine curriculum, believing that all patients deserve comfort, dignity, and choice. Welcome to the show, Dr. MacGregor.
Thank you. Thank you.
What would you like for me to call you? I know you have different names, so.
Well, growing up, I was Tamara Lynn if I was in trouble. It became my doctor name, but most people call me Dr. Mac. So
okay. I'll call you Dr. Mac for this show. Thank you.
Right.
I'm so glad that you're with us today.
Thank you.
Your work is commendable, and you have such a committed passion for it. What are you most proud of, though, in your life?
I'm most proud of my kids.
Tell us a little bit about your kids and why you're so proud of them.
Well, I had them when I was first in practice. So my first month in practice, I had a 3-month-old. And so they've made it through all the early practice. I mean, I in early rounding at the hospital, you know, I'd have one, you know, in my holder and the other one I'll hold by the hand. There's still people at the hospital that remember me with my 2 little kids. Now, 2 little kids are now 24 and 26.
Oh my gosh.
So, super proud of them. My son is David and he's 26 and he's brilliant, smart, science, wants to go into medicine and is waiting.
Yes.
My daughter, Rachel, is 24 and she's up in Boston. She got a Master of Public Health at Columbia and she's up there working, actually doing some research in COVID infected pregnant women.
Wow.
Yeah, so she's up there. We finally got to see her after the pandemic and everything. We hadn't seen her since Christmas. So it's really good to see her.
Oh, yeah. I know about that. I haven't seen my family since Christmas due to the pandemic and all of the social distancing and the sheltering in place. And so
Yes.
yeah, it's a really tough time for families right now, just to be apart because of the health reasons. And
Yeah.
I know she understands working in public health, how important that is. Right
Yeah,
now.
she in fact, she wouldn't let us come. She was like, no, you can't come. Dallas is too hot. So anyway.
Yeah. Well, that's great. That's great. Yeah, I'm proud of my kids too, but this is not the time to talk about that.
I know.
But what I wanted to know is you've been working in hospice and palliative care for a long time. What drew you into that? It's not something people just are drawn to normally.
Yeah, no, people ask me, you know, God, were you just depressed and did you just want to go into something sad? And I was like, no, not really. I remember hearing about hospice in residency. Medical school, maybe I knew that hospice, I thought it was a nice place with nice drapes where people went to die. I thought it was a place. I knew it had something to do with dying, but we never had any death and dying classes in school. We saw one sad movie, you know, my second year, I remember some sad movie. And then it wasn't really until residency when I started really caring for people more, heard more about it. And so one of my good friends actually said, I think I'm going to do hospice after residency. And I thought, oh, wow, yeah. And so it was in my mind. But it was really my first month or 2 in practice. In fact, it was the first Thanksgiving in practice. I had a patient who came in with his wife and had been coughing and coughing and coughing. And they had just moved to Texas. And I got a chest x-ray and it showed a tumor. And it was really, I think, the first time in really since ever that I had been the one that found the cancer. We arranged treatment, and, it was inoperable. And it was really the home health nurses that told me, he needs hospice. I remember being really dumb about it and going, oh, how do we get that there hospice, and they told me you have to ask. And so when I had hospice come and see him, they said, well, would you like our doctor to take care of him? And I said, well, patient, why don't you teach me? I often say that I was raised by wolves. I learned from my nurses. The nurses have taught me from the time I was a candy striper. I wanted to be a doctor. They said, we're going to make a good doctor out of you.
Yes.
And so, because the most important care, as we know, is the most basic. If your patient is not comfortable in all aspects, talk a great game, but if I'm not doing everything from here to their bottoms and back, they're not okay. So anyway, that patient went on to hospice, and I took care of him for the last few months of his life. And if I had it to do differently, I probably would have had him in the hospital, for the chest infection that he had, but we did get him home. That was his wish. And it was really about a year later when that hospice remembered me as two things. They remembered me as nice, me as teachable. And so it can be anything in life, be nice and be teachable.
Yes, absolutely.
And so they came to me and said, hey, would you like to do this job? And I said, well, 2 small children in a full-time practice, I don't need another job. And they said, well, look at this list. And so they showed me a list of the hospice eligibility guidelines. There's so many patients that I recognized from my training, when I just thought I must have been a terrible doctor because this person died and that person didn't make it. And it helped me sort of have realized that the reason those patients were dying is that they were dying. And it wasn't, I didn't know, and my residents didn't know, and my attendings didn't tell us or didn't know. I thought, wow, how can we all be so blind to something that happens to people every day? And so I kind of fell into it and then got really interested in teaching it. So immediately, as soon as I started doing hospice, I had to teach it.
Well, you mentioned something that some people think, or you even thought, that hospice was where people go to die. And that has been, I work in advanced care planning education for the past 14 years, and I work with underserved populations, predominantly African-American communities, on teaching around advanced care and how important it is to let your wishes be known. And in case you have a life-threatening illness or accident and you can't speak for yourself. So I will talk a little bit more about that, maybe a little further in, but what you said was striking to me, is that you even thought that hospice was a place where people go to die. Can you tell our audience a little bit more about what hospice really is, and also what the difference is between hospice and palliative care?
Absolutely. I teach now, and well, as soon as I learned it, then it became very important to me, because I thought, wow, I went to UT Southwestern, I should know this. John Peter Smith, I should know this. And I guess I was just too busy making it through, missed that fine point, about it, but I don't remember learning about it. Hospice is wherever your patient is. Wherever the patient is, hospice comes to them. So if they're able to be home and safe and comfortable, and medical care can be provided for them at home, then that's what we do. If the family is not able to care for them at home, it's too difficult or too physically taxing, or their care needs are too high, then hospice can be a facility like a nursing facility. Hospice can also be at a nice place with nice drapes, so there are hospice facilities. And then you can even have hospice in the hospital, really for the most acute. So if someone really is not able to make it out of the hospital, it may do an in-hospital hospice care. It doesn't make sense, they're not going to be aware that they made it home. My first hospice patient made it home, and knew it. And that was our plan. Our plan of care was to get him to his house.
Yeah.
And he was very happy, and his wife was grateful.
Mm-hmm.
But hospice is definitely wherever your patient is. It is reserved for patients that have a best guess prognosis, 6 to 12 months or less.
Mm-hmm.
I tell people my crystal ball broke a long time ago.
Exactly.
Based on my experience with other patients with different diseases and the training that I've gotten over the years, and the smart nurses that taught me things to start with, and then the extra training that I've had, helps me understand and get an idea where a person is in their journey. You know, are they early in the disease? Is it moving rapidly? Is it slow? And how might we be able to help? And so that's kind of when I'm looking at whether or not a person is eligible for hospice, it has to do with, you know, what is their disease and how extensive is it?
Mm-hmm.
What other complications have they had with it? Have they had any life-threatening complications in a recent time? Is home health more appropriate for that person? Is rehab more appropriate for that person? Or is hospice more appropriate for that person? Now, come from the roots of hospice comes palliative care. And so I knew about palliative care when I started doing hospice in the 90s, but it wasn't well established. It was mainly in the Northeast and in the Northwest and California. And we knew that palliative care meant that you don't have to have a 6-month prognosis, but that indeed you can have years. You can have some years. If you have a life-threatening problem and significant symptom burden, then it fits criteria for palliative care. And so I've actually done more palliative care in the last 10 years than I had done previously when I was doing mostly hospice. But that's because of my association with the medical school. That enabled me to sort of expand in that. Did a lot of in-hospital palliative care for about 10 years, and now I'm doing more clinic-based palliative care.
And yes, we know that hospice and palliative care are actually services given to the families. It's not really a place, like you said, that the patients receive those services and benefits. One of the things that I've noticed in my work with this, and also in the research too, is that the percentage of African Americans that actually utilize hospice services is about 8% of the U.S. population, of that population. I know.
So low. Yeah.
8% of whites. It's such a vast difference in usage.
Yeah. It seems better. But it may just be that I want it to be better. When I first was doing hospice, I was told, you know, the most common patient that gets hospice is an old white lady. And it's not that it's not offered to others, but it was more readily accepted, I guess, by the families of and the patients of that fit that demographic. But I feel like that the early conversations I had when I was first doing hospice, first of all, when I came to Dallas and was doing family medicine, and I told them I was a hospice doctor, they were, you know, making Kevorkian jokes and things like that. And I was like, that's not what I am.
Right, no.
But palliative care really it didn't have good penetration into the hospitals. So when UT Southwestern needed a palliative care team, I did get asked by Dr. Elizabeth Paulk, who's amazing. She grew up at Parkland and started the palliative care service there just from the roots. And so she asked to help create a consult service at the university hospitals. And so that's when I started doing that about 10 years ago. But it has become much more accepted and much more ingrained. Many more people have kind of heard of it. I can say hospice without scaring people to death. I can bring it into normal conversations more now. And I've been saying it so many years, maybe I'm better at it.
Yeah.
But I do feel like that I have more African-American families and patients, but maybe it's just wishful thinking.
Yeah, it is really low. And part of the reason for that, though, and you probably are familiar with that too, is that the historical mistrust of healthcare systems, the disparaging treatment, and also misinformation that's out there. There's a lot of misinformation that passes through, and then one of the main things that I've noticed or learned about in my work is that it's due to cultural differences and spiritual beliefs and values that are not necessarily the same as Western medicine, the model of Western medicine. It uses more of an individualistic model in terms of how they approach their patients. And you know, Black people and a lot of other people of color have a collectivist view of how they see the world. And those clash in many cases, I think. So the miscommunication of not understanding perhaps how important it is to see the differences or the diverse differences based upon cultural values, norms, and beliefs that generally are associated with certain groups, you know.
Absolutely.
And I'm really excited to hear, though, that you are working with medical students to help them better understand, too, how important it is to be culturally responsive to diverse peoples, that all people get the comfort and the dignity and the service that they need.
Well, thank you. Yeah, I learned right away I could teach the young ones better than I could teach the ones that already had their minds made up.
Oh, wow.
Trying to go out and teach community doctors wasn't working for me, but going to the residencies and the students, you know, their learning curve is straight up. And so you can give them the right view, not the right view, but a correct view.
Exactly.
And dispel myths before they get ingrained.
Yes.
So I do absolutely love it. I love seeing the light go on for them.
Yeah, I teach, I'm an assistant professor in social work, and I love that too. I teach master students who are about to go into this world to serve people. And one of the things that I love doing is teaching around social justice and bringing awareness of how differences mean. Diversity just means differences. It means different ways of being in the world, but it doesn't mean that we're not all human beings. And so it's pretty awesome to have that type of position. And then for you to do that, also, not everyone is open to change, or even to seeing those differences in a socially just way.
Yeah.
You know.
Yeah. Well, and I feel very lucky to be at Parkland and UT Southwestern. I was in private practice for a few years, and I missed the mission. I missed the helping people that really didn't have enough, and so getting back in that and then being able to work, you know, through all levels has really been a great privilege, honestly.
I know that you've been working with different patients in that way, but how has having advanced care documents in place helped patients that you cared for in that capacity?
Well, it becomes really one of the things I teach, and one of the things that I have learned is that if I don't know where they came from, I don't know where they're going. So amazingly, you can get an entire medical history and not know your patient or not know what their support system is. I have to know who helps them with their medical decision making.
Yes.
So driving advanced care planning, I say, who's your voice?
Yes.
You know, if you could not speak to me, who is your voice?
Yes.
And then I want to know what you would want if you were at your very end. You know, years from now, in advance of needing to know, I want to know what you would tell your family and me that you would want. Would you want to be kept comfortable and allow to pass naturally, or would you want to be kept comfortable and on all possible machines?
That's one of the things that I'm very passionate about, and we share that commonality too, is that I believe that patients and families actually need to have those conversations to know what someone's wishes are and have that voice, have advocacy in that system. Because in healthcare, we know that things are not all the way that they should be. There are broken systems actually that are at play, and navigating that is really challenging when you're well. So when things are not well, and especially in cases where you can't speak for yourself, it's really important that you have that voice, someone who knows what your wishes are and that can make sure that they advocate and get that done for them.
Absolutely.
So yeah, absolutely. As an essential healthcare worker in this pandemic environment, with all the high numbers of deaths and infections and social distancing and all the factors that you guys are dealing with, what gives you joy and keeps you going?
I think really it's a connection. If you can't connect physically, you have to connect through communication. And so strangely teaching, I thought I could never teach, you know, without having the students in front of me. I'm never going to be able to do that. Then we went on and had 4 months of online teaching, just one after the other. And interestingly, I could get up close and I could call them by name, and then they can call me back by name. I think it's still connection. It's still connecting with people in whatever way we can. It's like we get energy from each other.
Yes.
If we're not near each other in some way, then we dwindle.
That's so true.
I feel so hard. I feel so bad for people who don't have that resource or don't have that connection. It's very hard. I think it must be very, very hard.
Well, it's great that you get joy from teaching and helping others. And it has been a pleasure for me to talk with you and to let our audience hear more about, you know, your side of the work in terms of helping people at the end of life. So I just really appreciate you being a guest on Heart Talks, and thank you so much.
Thank you, Gloria. Thank you so much.
And thank you. Thank each of you for being a part of this conversation today. Thank you for being a part of the Inspiring Insights community. I pray and hope that something was said to inspire your heart and encourage your soul. And I look forward to seeing you again next week. Have a wonderful week. Also, just stay safe, be well, and I'll talk to you soon. God bless you. Bye.